Hi, this is Liz Whittaker, one of the pediatric infectious diseases consultants at St Mary's Hospital in Paddington. And today I'm talking to you about COVID-19 disease in children, focusing on clinical illness, including MISC, or as we call it in the UK, PIMS-TF. So just to, as an overview, I thought I'd explain that in England we call this pediatric inflammatory multisystem syndrome, or PIMS. And as you can see, it's named after a favourite drink, whereas in the US it's known as Missy, and this is Missy Elliott, which is as close as I could get to an approximation. So just how much of a problem is COVID in children and SARS-CoV-2 infection? And what you can see here is that in children, severe disease is extremely rare, so it makes up about 2% of all disease experienced by children. And looking at this graph here, what you can see is the age and sex of patients admitted to hospital. In purple are those who died as a proportion of the total. In yellow were those still in care, and pink were those who had been discharged. And young people under the age of 30 are barely represented at all. This is really a disease of the elderly. And then when we look at a breakdown of that 2% who do have severe disease, the majority of those are over 15 or under a year of age. And this is in particular looking at hospitalised patients. And this probably reflects the fact that we're more likely to admit an infant than an older child, just out of caution, apart from anything else. When we look at the symptoms, 30 to 50% of patients are asymptomatic. And this is a systematic review of all of the publications to date. Most commonly, children experience fever and cough, which we can see here. And then there's between 10 and 20% of other symptoms, including upper respiratory tract symptoms, diarrhea, etc. So what we're really worried about is the other things that affect children during the pandemic, and these are predominantly not medical. So unemployment, domestic violence, lack of access to vaccines, etc. So I'm just going to run through a couple of classic case scenarios for severe COVID disease. This is a 14-year-old boy who had contact with his mum a week before presenting, and she had coronavirus. He got classic flu-like symptoms and then progressed to having difficulty breathing and was admitted to hospital on day 5 of his illness. And unfortunately, he progressed quite rapidly to intubation and inotropic support. And you can just see his chest X-ray here. He was transferred to Great Ormond Street as an ECMO referral, and was given remdesivir on compassionate use. And thankfully, after 10 days in intensive care, he was actually extubated and discharged to the ward, and over a week later transferred back to his local hospital for rehabilitation. But just in context, this young man had a very high body mass index, and we know that obesity is a risk factor for severe disease in this cohort. He had no other medical problems of note. The second case is an ex-premature infant, a 32 plus 6 weeker, born from a twin pregnancy to a mum who had preeclampsia, had a small ASD, but otherwise was quite well and went home at about 4.5 weeks of age. Unfortunately, he had a contact whilst on the neonatal unit, and whether that was staff or family is a bit unclear, but both were unwell. This was at the peak of the pandemic in April, and unfortunately bounced back into hospital through A&E with respiratory distress. They struggled to intubate him, and he was actually transferred with just a laryngeal mask and had to be intubated in theatre. And he turned around quite quickly from a respiratory perspective, and they gave some dexamethasone prior to extubation. However, before they managed to extubate him in the next 12 hours, he had a significant deterioration requiring high-frequency oscillation, nitric and inotropes. He again was treated on compassionate grounds with remdesivir, converted his PCR swab to negative, and was discharged to the ward by day 18 of illness. And I just highlighted those because I think these are the classic age groups and problems that we've seen at the severe end of the spectrum. And I thought it's useful to think about what we're treating these children with. This is data from a voluntary study. It's not a study, it's an audit and survey where people voluntarily put information on from around the world. You can see here on the map where they've come from. And about 56% of severely unwell patients in intensive care are treated with remdesivir, and about 70% with steroids. A small group is still being given IVIG, and an even smaller group again having some convalescent plasma, both of which are more on the investigational end of the spectrum. And we are giving a low molecular weight heparin to about 2/3 of these patients. But we're not using any hydroxychloroquine, lopinavir, ritonavir, which is all good since they've not had any evidence of benefit. And it's just worth thinking about when we're testing our viral treatments. So patients present in the beginning when they've got lots of viremia, and by the time they become unwell and come to hospital, they're actually in an inflammatory response phase. And this is when we start to give antivirals. So given that their viral load is already dramatically decreased, it is difficult to understand how much we can look at these studies. So from remdesivir, since that's one of the treatments we've been using, I would say the data in adults is interesting. And I think that there is still a little bit of a question about whether there is benefit, although it is clearly not the wonder drug that we were hoping. So this is the WHO Solidarity study from a preprint showing no benefit in remdesivir over controls. And this is particularly the case in ventilated patients. There may be a benefit in giving it earlier, as explained in the previous graph. I think that's still up for question. What we don't know is there is no data on children at all, apart from some safety data. So we have no efficacy or outcome data. Thankfully, the safety data is reassuring. Really, we need a randomized controlled trial, and Caravan is hoping to answer that question, which has opened in the US in the last few months. A better preparation that could be given to outpatients who presented who are vulnerable or susceptible at an earlier stage may well be really beneficial, and nebulized products are being developed. And is there a role for giving it alongside immunosuppression if there's viremia and we give, for example, dexamethasone? Do we need to cover for increasing viremia by giving it at that point? Dexamethasone is the other drug that's been used quite a lot, and this is based on the UK recovery trial, which was a randomized controlled trial of a variety of treatments, including hydroxychloroquine, standard of care, dexamethasone, lopinavir, ritonavir, azithromycin, and more recently tocilizumab and convalescent plasma. So another of these arms have stopped, including the Drug Safety Monitoring Board stopped the dexamethasone arm for efficacy. And this just shows you a decrease in mortality across all participants of 17%. For those who are in oxygen alone, it's 20%. But by the time you're needing invasive ventilation, there is a 35% reduction in mortality with dexamethasone. Interestingly, there isn't a particular increase in those who are not severely ill. And this is clearly addressing that point on the graph that I showed you before, where these patients were very inflammatory. So currently the recommendations for adults with coronavirus, SARS-CoV-2 infection who are mechanically ventilated and on oxygen should receive a 10-day course of dexamethasone. Safety and efficacy, again, has not been evaluated in children who have COVID disease, and our recommendation is that this is discussed at an MDT with the ID and intensive care teams for children with severe disease. There is potentially a role for acute respiratory distress syndrome due to other causes. And then a whole different thing happened towards the end of our lockdown in the UK. This is an example of PIMS or MISC. It's an 11-year-old girl who presented with fever, abdominal pain, myalgia. She was admitted to her local, and they thought she had abdominal sepsis and gave her broad-spectrum antibiotics, but unfortunately she deteriorated and required fluid resuscitation, inotropes, IVIG, and her blood picture worsened. At the time, she was our first case. There was a real question about what the differential was, and we hadn't come across this hyperinflammatory syndrome. We thought she might have toxic shock. However, she just wasn't managing to maintain any blood pressure despite being on maximal inotropic support, and in fact, she arrested several times. She was transferred to Great Ormond Street for ECMO and received high-dose methylprednisolone for 10 days. She was extubated after 16 days in total and actually has been remarkably well given everything. She had some critical care myopathy and a small thrombus in her right anterior internal jugular, but actually she went home about 10 days later. She had physio and psychological inputs at home and has made a full recovery, which is really remarkable given how well she was here with us on day 3 of illness. Now, this is just an example of the severe end of the spectrum of PIMS-TS. So what did we see in the UK? This is a paper in The Lancet, just looking at 78 patients who were admitted to 21 of the 23 critical care units in the UK. And what this graph shows is the blue line is the number of patients we'd expect to be admitted, and the green line shows what happened instead. So a really dramatic increase. Predominance of male has been seen in adults with severe COVID-19, relatively old with a median age of 11 compared to our normal intensive care admission age, which is generally lower, and a median observed to expected weight ratio, which is greater than expected. Now, all of these children had heights charted to calculate their body mass index. The majority of them didn't have underlying comorbidities, and there was a predominance of Afro-Caribbean and Asian populations, which I think really, rather than there being an ethnic risk to developing PIMS, it reflects where there was a lot of viral transmission and there an increased risk of having illness. A small proportion were PCR positive, but the majority had positive SARS-CoV-2 serology. And we really didn't see that much co-infection. So these children have a fever, rash, conjunctivitis, abdominal pain, diarrhea, vomiting, and headaches. And in addition to that, they have really quite a lot of inflammation on their labs. And on the whole, supportive care is the basis of treatment. Really keen that people don't overlook common treatable conditions like sepsis, Stevens-Johnson syndrome, etc. So just to be aware of the differential. And what was worrying about this cohort was that about a third of them went on to develop shock with profound myocardial dysfunction, often ECG abnormalities, and about 10% of them getting coronary artery dilatation. And so in total in the UK to date, we've had about 250 children. I know that's quite a low number compared to the US and other places, but given our population, it's not insignificant. They tend to have an inpatient stay of between 7 to 10 days, with 3 of those being on intensive care. We've had 1 death as a consequence of complications of ECMO. And looking at Spanish data, it looks like about 1 in 5,000 children who's infected may get this, although I suspect this is overstated and it's lower. So in our JAMA paper, we described 3 main cohorts. That shocked group, like the case I've shown you, a group who look more like Kawasaki disease, but have a higher median age than we would have expected. And finally, a group who were febrile and inflammatory and really just didn't fit either cohort. This group had the worst outcomes. The 3 children who had ECMO in our setting and the 1 death were in this group, and none of the other group had any ECMO. But concerningly, we saw coronary artery aneurysms in all 3 groups of children, all of which were managed with slightly different treatment modalities. So there's been a lovely paper by the CDC, by Shanna Godfrey-Cato, just looking at their phenotypes, and what they see is about a third have that same shocked cohort as us. And like we saw, the majority of these were serology positive and PCR negative. They had that group who looked more Kawasaki-like with mucocutaneous involvement, and 2/3 of those were serology positive. But then finally, they have a group who actually could potentially be severe COVID. They have quite a lot of respiratory involvement. They're much more likely to be PCR positive. And this group had the worst outcomes and the highest case fatality rate. But interestingly, a subset of them had coronary artery aneurysms as well. And it may be that this is actually picking up a mixture of patients who had severe COVID and PIMS. And we really need better ways of discerning between the two. As yet, we don't really know what the mechanism is. Because there's a delay of 4 to 5 weeks after the infection, it's postulated this may be antibody-mediated, and there are overlapping features with a variety of other conditions like Kawasaki disease and toxic shock syndrome. And just a reminder, so in red, you have mucocutaneous features, lymph nodes, skin rashes, and heart involvement in patients with Kawasaki's. And in our PIMS or MISC cohort, there's additionally neurological changes, respiratory involvement, and quite a lot of GI upset. And in Kawasaki, they tend to be younger than the group with PIMS. When we compared our cohort with a cohort from with Kawasaki and Kawasaki disease with shock and toxic shock, what we saw is that our cohort were profoundly inflamed in comparison, that they were sick with low lymphocyte counts, low hemoglobin, low platelets, and low albumin, and worryingly, they had much higher cardiac enzyme abnormalities. So Claire Wilson, who's a PhD student in our group working in the Diamonds and the Perform cohort, which are 2 large cohorts of children with fever from across Europe, compared again these same features. And these children with MIS-C or PIMS are significantly more inflammatory than those with other conditions, and these include a variety of causes of critical illness. They've also got lower platelets, are older in age, and have a lower lymphocyte count. So we're in the process of developing algorithms that may help to identify some of these illnesses. And how are we managing these children? So that same survey that we looked at before shows that about 3/4 get steroids, 3/4 get IVIG, and then a variety of other treatments are represented. And what is concerning is that this is all based on anecdotes and expert opinion. And this graph just shows you that at the beginning, there was 1 or 2 patients, and by the end, 1 or 2 treatments, and by the end of the outbreak, all the patients were getting all the treatments. What's important is in our original cohort, about 13 of the children got better with no sequelae, without any treatment apart from standard of care at all. And that should just be borne in mind. So we've done a national consensus using a Delphi process. And again, as I said, consider the differentials, consider an MDT, talk to your friends and colleagues, and then treat based on phenotype. So with shock, you probably need to be more aggressive using steroids and IVIG. In the Kawasaki-like group, they should be treated like Kawasaki. And with the others, there's probably time to take. And we would really recommend, if there are treatment trials available, they should be used. We're really happy to say that most of our population at 6 months have made a really good recovery clinically, but we are seeing significant amounts of behavioural and psychological morbidity, as well as lots of COVID fatigue. And it's been a hugely challenging thing to establish multidisciplinary clinics. In the next few months, we're hoping to understand more about PIMS. We know a little bit from this nice paper from Consiglio et al. In Cell, which shows in the first instance that there are differences. This is adults and this is children using principal component analysis. Interestingly, no difference in antibody, which was interesting to us. In pink here is Kawasaki, looking at IL-17 is quite distinct from children with COVID, well children or children with PIMS-TS. What I'm trying to show you here is that this cohort of children with MIS-C or PIMS-TS had no previous cross-reactive coronavirus antibodies, and the other 4 groups that they looked at did. So the antibody story keeps on giving. Lots of great work happening in the US and the UK, some treatment trials and some observational treatment websites. Really encourage you to put your patients into this if you're seeing any with PIMS. So in summary, severe disease is rare. It's really crucial that people do a multidisciplinary team approach to this, because this is rare, and so it's important to talk to other people and compare experiences. Most of the treatments we're using are extrapolated from adult data, and where possible, we should try and put these children into treatment trials. And there's a crucial need to follow up these children to know what the long-term sequelae and outcomes are like, and in particular, to look at the long-standing pathogenesis and what happens if and when they meet COVID again. And there may be a relevance both for adults and for understanding vaccine safety. I'm going to end there slightly over. So thank you for listening. Happy to take any questions. Here are my acknowledgements.